Hello everyone. Hi, how are you? Okay, let's do something here. Let us do something and go to settings. Let us restart this capture. Okay, here we are. Okay, here we are. Let's go to Pulmo. Let's do some. What condition is caused by fluid in pleural space? It's caused by fluid. What would you want at? That pleural effusion. Well, that was pretty easy. I mean, okay, name two types of pleural effusion that developed from, like, one is hydrostatic force, which is your transitate. Then you increase capillary permeability. That's your, no, that's exudate. Yeah. I know how I'm good, but, like, what is the mechanism for this? I mean, I thought we just discussed this. Transitive was hydrostatic force. Exudate was increased capillary permeability. Like, I think it's pretty obvious. Like, I don't think anyone here exempts that. Now, in exudative pleural effusions, increased capillary permeability is what two things leak in the pleural space. Well, if it's exudative, what would you want it? I know one is plasma, blood, RBCs, and then protein. So protein and cells. Okay, protein and cells. What is Light's criteria used for? Is for differentiating exudative versus transitive. List three components of Light's criteria. So we have, wait, the protein. Let me think. There was one was like the pleural protein to serum, which is like more than 0.5. I think the LDH to serum LDH more than is like 0.6, and I think the if you're comparing like pleural to, I think, yeah, it'll be like more than 2/3 of the serum LDH. So yeah, see, look at me. I'm just good. I'm just good at this. Okay, so like transitive pleural effusion, what will be the color? The LBCs will be there or no? What is the pH? Well, it will be acidotic. Glucose, I think, will be a little bit there, like decreased, but it's usually always pretty normal, normalino. Straw colored, see a little bit straw. This is all minimal. So transitive is like a pretty minimal version of your exudative. Okay. I guess it's okay. Don't mind me yawning. Okay, I just woke up. Okay, I'm a hard worker. What is the most common cause of this? We know one is like you have like cirrhosis, CHF, and then nephrotic. So between them, so heart failure. Okay, cool. Now transitive pleural effusion. I just said that. Like, I am great, but like I don't know. I was like too good. Additional findings in heart failure patient with pleural effusions. I mean, come on, like, dude. Lung pathology, physical exam finding pleural effusions, and then lab findings. So what is a lung pathology? I mean, there's fluid in the pleural space. Additional findings heart failure with this. You may have crackles. You may have, that's physical exam finding crackles. Lung pathology would be a little bit, I don't know, distorted. Lab finding, what do you have? What do you have? I know BNP, but like, what's the other thing? GBDD, pulmonary eddy. So pulmonary edema, then you got JVD, and you also have BNP. Okay, I guess so. Okay, what is the mechanism by which nephrotic produces transitive pleural effusion? I know, well, what does it do? It releases, I mean, there's loss of albumin, and that is unable to maintain hydrostatic forces. So you decrease oncotic pressure from albumin loss in urine. So decrease that oncotic pressure, you little d. Okay, so what are the pleural effusion due to cirrhosis called? Wait, hepatic hydrothorax, and then what is the most common location? I think that was the right side. Yeah, see, I'm better. I'm so good at this. Like, I'm the best. I really am the best. How does this cirrhosis lead to pleural effusion? Well, one thing is cirrhosis, there will be loss of like protein formation, and because of that, there will be loss of that. Or it could just be ascites flows into pleural space. Oh, wow. That simple as that. Okay, so 3 physical exam findings in patients with pleural effusion due to cirrhosis. Well, jaundice. I mean, and also like pulmonary edema. No, but like they said physical exam findings. Yeah, jaundice you can have, and then maybe also like, because it's like lung thing, like jaundice you can have spider angioma. So it's basically like whatever you have in cirrhosis. Okay, thanks, man. Most common cause of exudative is obviously going to be your TB. Okay, it's pneumonia. In India, it's TB, but yeah, pneumonia. Let's do that again. And we gotta do that again. Causes of exudative, like pleural, that effusion. There's TB. We know pneumonia. We know We know esophageal like trauma. We know pancreatitis. We know that there's also parapneumonic effusion, chyloma, rheumatoid arthritis, SLE. Um, then there's like other stuff that I don't remember very well. I did what? I did like eight. So there's like four more. So I guess like malignancy, then um, well that's chyloma, right? Lymph or maybe not so much. I guess also like pneumothorax. I don't know if they call it pneumothorax, but I don't remember the name. And then there was like if there was a esophagia, there'll also be like an abscess. I remember there was like a liver abscess or something that caused it. And what was the other thing? It's 10. So pneumonia, parapneumonia, TB, malignancy, pulmonary embolism as well. So you have pulmonary embolism, pancreatitis. Yeah, we kind of knew that. Abdominal abscess. Yeah, okay. And then pulmonary emboli. Okay. Then rheumatoid arthritis, SLE, esophageal pancreas, hemothorax, chylothorax. So you call it hemothorax as well. Okay, so that is hemothorax. Okay. Yeah, I guess. Yeah, that is hemothorax. The chylothorax, we kind of knew that. Esophageal, abdominal. Okay, good. I am the greatest. Okay, cool. So I guess we got that. Just, you kind of have to go and then just signs and symptoms of like parapneumonic, like Effini. Okay, so what is the parapneumonic? If you anyone watching, you gotta watch my videos, dude. Like, come on, let's go, dude. Like, you gotta like watch it. Show the thing, dude. Okay, so I guess I don't have my chat on, so refresh that. And then okay, cool. So we got that out of the way, and then signs and symptoms of parapneumonic effusion. So online fighting, I guess the pH thing, and then you also have like others. So oh no, never mind. It's fever, cough, sputum production, and your WBCs. Wow, cough, sputum production. Where's the WBC? Okay. All right. And then fluid analysis of uncomplicated parapneumonic, like an effusion. Wow. That means it's not too acidotic. Glucose is still a little bit controlled. Increase the normal glucose, normal pH. Okay, good. The bacterial invasion of the pleural space. Oh, that's complicated parapneumonic effusion. Okay. In that one, yeah, you got your glucose less than 60, and then you got your acid levels that's like less than 7.4, and then you also have like increased WBCs, positive Grammys, get gram stains there. We got that in. Okay, cool. Signs of TB. We know that there's night sweats. You'll have like fever again, and then weight loss. Okay. And then what do you have? Yes, there will be WBCs. Yes, there will be like ADA. You'll have like I think an LDH increase, and also, well, acid fast and then gram stain. So yeah, protein LDH. Oh, protein also increases. Hey. Protein. One thing I didn't mention the protein. So you gotta get it out of the way. There was a malignant pleural effusion develops. How does that malignancy get in the way? So you got hematogenous, you got lymphatic contiguous. Man. Alright, so in reference of a malignant pleural effusion, they're elderly smoker. Yeah, I knew that, bro. Like I'm just good at it. I'm just good with this. Now, malignant pleural effusion, pleural fluid analysis. I guess you'll have like lymph. You'll have like the same pH. So you'll have RBCs, you'll have lymphocytes, and you'll have malignant cells. So there's malignant cells in that. Yeah. Okay. Malignant cells. Okay. And then you have RBCs increased, lymphocytes are increased. Okay. All right. So diagnosis of malignant pleural effusion. What is diagnostic test? I guess just go for like biopsy, pleural fluid cytology. Cytology? Now, what is the mechanism for pulmonary embolism causing pleural effusion? Because of pulmonary emboli, okay, there could be an infarct, and that infarct causes the infusion. There's no reasoning other than that. Now, a pulmonary embolism, the symptoms, okay? What are the symptoms, the vital signs, associated conditions? well, I know one is like you have like chest pain. You know, me, I also have like dyspnea. Vital sign is just your respiratory rate sort of increases. Associated condition, tachycardia. Okay, and then signs of lower extremity, DVT, bro. DVT. Okay, okay. That was kind of good. Now, autoimmune disease, we know there's like SLE, there's like rheumatoid arthritis. What's the other one? Was there another autoimmune disease that we didn't know? Oh no. And then decrease the pH, decrease the glucose, and lymphocyte predominance. I think we kind of knew this. I think what I remember in rheumatoid, I think rheumatoid had a little bit more blood. Rheumatoid was more extreme. Okay. The vital sign here is the lab finding is the same, I guess. Lymphocytes and vital sign is like fever. Damn. And increased WBC. Feverini. Okay. I mean, all right. Okay. What part of your sphincter usually involved in rupture? It's the, if I remember, it's the left side. Left distal esophagus. Okay. It's on the left side. On the left side. Okay. So from the left side. Okay. Left distal esophagus. Wow. Okay. Esophageal rupture. Symptoms: pain, vital sign, fever, and then lab find WBC. Common cause of esophageal rupture. I guess it's because of like endoscopy. So I guess you saw iatrogenic endoscopic fluid analysis. We kind of knew this, right? Like the WBC, maybe pH will be low, glucose may be decreased. Okay, amylase is a new thing, so you will get like the amyle. Where's your amylase? Yo, where the dog? Where the dog at? We contain undigested food. Amylase increase, decrease pH. Okay, so glucose there. I kind of like it. Undigested food, amylase is your favorite. It has pleural effusion. Prognosis: poor, because he's on a stretcher. That's what he knows. Poor. Okay. Increased cavity permeability allows the 1-2 things to leak into pleural space. I know one with cells and protein. So I am the chief, but chief complaint of pancreatitis will be like severe pain radiating to the back, like epigastric pain radiating to the back. Pleural fluid analysis, pancreatitis. I guess the same stuff. Like there will be increase in the amylase here too. Wow, look at that. Hematologists, I think, also have like hematocrit like more than 50%. Wow, dude. Okay. Pleural fluid to serum hematocrit like more than 50%. Damn. What's the most common cause of hemothorax? Trauma? I guess I was right. Trauma of the big trunk. That is your aortic rupture. Cause of chylothorax. Huh. I mean, malignancy was one. You also have surgery. I like that. Surgery can also cause it. Now, pleural fluid analysis, chylothorax, Chylosaurus, as they call it. There's WBCs. What's the other thing? Protein. Increased triglyceride is a new thing. So triglyceride is a new thing. So milky as like triglyceride, as important. Okay, so we kind of know that this is loss of oncotic pressure. Lung pathology, pulmonary edema. Physical exam finding for pleural effusion. Lab finding, BNP, JVD, but like, hey, listen, I got it. Cause of exudative pleural effusion, that's just here, Jeff. I'm sorry, that was pneumonia. Oh my god. There's loss of like, protein was no, just like, sinus flows, okay. Lab finding would be, so what were the symptoms? I guess there's WBC, fever, cough, sputum production. With malignant pleural effusion develops. So that is your greatest way. To like, I am the best. Like, there's no one that could like outbeat me. 3 ways a malignant pleural effusion develops. Okay, 3 ways. Alright, let me think. My brain isn't on right now. Malignant pleural that BB. Oh god. Three melanin pleural effusion develops. What? I don't know. What was the melanin way of producing this? Heterogeneous, okay. Heterogeneous, lymphatic, and contiguous. Okay. So let's just do that. And then pleural fluid analysis of this melanin pleural effusion. You'll have neutrophils. You'll have like I guess pH low, glucose low, no lymphocytes, RBCs, and melanin cells. Okay. Now, a pleural fluid analysis will show for complicated pneumonic effusion would be, I don't remember. Okay. That would be, what would it be? What could it be? Political analysis, complicated parademonic effusion. Huh. Okay, so I'm kind of like lost out of it, but pleural fluid analysis, I think we kind of know. pH will be low, glucose low. You'll have like what was it, gram stain, and then there's like I think WBCs, which is like okay. TB was a one epinephrine protein, mechanical pulmonary blood, that's your infarct, and then symptoms here, DVT was 1. Yeah, you have tachycardia. Yeah, and then vital sign here was fever. Yeah, and then pancreatitis. What would you have in here? Just the myelitis. Pneumothorax is your trauma, aortic rupture, and then here you'll have pleural hematocrit serum hematocrit more than 50%. That's with pleural effusion. What is the prognosis? What would be the prognosis? Pancreatitis with pleural effusion. Poor. And then chylothorax causes are, well, malignancy, pleural trauma. I'm sorry, it's your like iatrogenic surgery. Pleural fluid analysis of like esophageal rupture. What is a pleural fluid analysis? Esophageal rupture, myelitis is 1, WBCs for sure, pH glucose. There's one more, I think. Making undigested food, yeah. And then chylothorax, you had like, what did you have? You had cells, you had like, no, you had milky, and it's triglyceride, yes. Malignant, they have RBCs, malignant cells, and then you also had WBCs, so yeah, there you go. 3 ways malignant, that's homogeneous, lymphatic, and like that contiguous.